Welcome to Invasive Lobular Carcinoma, highlights from the first ever ILC Symposium. My name is Stephanie Blaufarb, and I'm the program coordinator at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit that for the last 40 years has people through breast and ovarian cancer, offering support from folks who faced breast, ovarian, and metastatic cancer. SHARE offers many services, including helplines, telephone and in-person support groups, and educational programs. All services are free of charge to participants. For more information, visit our website at sharecancersupport.org. All participants will be muted during the presentation. When the panelists finish speaking, our Director of Breast Cancer Programs, Christine Benjamin, will moderate the Q&A period. You're welcome to submit questions throughout the presentation through the question pane in the control panel on your screen. Remember, when asking questions, the presenter is unable to give specific medical advice, so please keep your questions general in nature. We will do our best to ask all questions, though due to time constraints, not all questions will be answered. This webinar is being recorded and will be available on the SHARE website soon. In September 2016, the first International Invasive Lobular Breast Cancer Symposium took place in Pittsburgh, PA. Steffi Osterreich, PhD, and Rachel Jankowitz, MD, of the University of Pittsburgh Cancer Institute, together with Leigh Pate, breast cancer advocate, will offer an overview of the ILC as well as highlights from the conference. This webinar is in collaboration with Metastatic Breast Cancer Network. The Metastatic Breast Cancer Network is a patient-led organization that provides information to patients through its website, materials, and regional patient meetups. It also advocates for more research that has potential to lengthen lives until cures can be found. Today's speaker has been selected by MBCN to receive a 2017 Research Leadership Award, made possible by donations from individuals, families, and private companies. Find out more at mbcn.org. Now I'd like to introduce our speakers. Steffi Osterreich is a professor of the Department of Pharmacology and Chemical Biology at the University of Pittsburgh Cancer Institute and Director of Education at the Women's Cancer Research Center at McGee Women's Research Institute. Dr. Osterreich's laboratory aims to further the understanding of estrogen action in breast cancer with the goal to use this knowledge for improved diagnosis and endocrine treatment of breast cancer patients. Her research has focused on invasive lobular breast cancer, a disease that is mostly estrogen receptor positive and that has been understudied. Rachel C. Jankowitz, MD, is an assistant professor of medicine in the Department of Medicine Division of Hematology Oncology at the University of Pittsburgh School of Medicine and the University of Pittsburgh Cancer Institute. She has an active medical oncology practice centered around care of patients with breast cancer, and she serves as the medical director for the UPMC McGee Women's Hospital High-Risk Breast Cancer Program. Her research focuses on invasive lobular carcinoma and tissue-based biomarkers in hormone receptor-positive breast cancer. Leigh Pate is a Seattle consultant, writer, lobular breast cancer survivor, and breast cancer patient advocate. She's a member of the steering committee of the ILC Advocacy group. She is also active with the National Breast Cancer Coalition, and she is a patient advocate at Fred Hutchinson Cancer Research in Seattle. Now I'll turn it over to the panelists.
Yeah, hello, this is Steffi Osterreich. So we look forward to giving you an update about our understanding of invasive lobular breast carcinoma. As it was just said, we had the first meeting on invasive lobular breast cancer in the last fall here in Pittsburgh. On the first slide, you can see some photos from this meeting. It was really an outstanding opportunity to get the researchers and scientists and clinicians who work on this invasive lobular cancer together. And what was discussed, we are going to share with you here today in this webinar. I have to say, a unique aspect of the meeting is that we were lucky not to have only outstanding scientists at the meeting, but also advocates who really felt their voices heard at the symposium. On the bottom, you can see we were very fortunate to get funding from a number of organizations for this meeting. On the next slide, you can see the main research areas which were discussed, which was epidemiology and genetics, the unique pathology in invasive lobular breast cancer, imaging. unique biology of primary as well as metastatic disease, early disease, lobular carcinoma in situ, surgery, and finally we had a session on preclinical studies and therapeutics. The meeting was so successful that at the end, all of us decided that we are going to have another one, and this will be in 2018, next year, in Boston. So what about frequency of invasive lobular breast carcinoma? Although it only represents 10 to 15% of all breast cancer, it is very frequent. It affects approximately 30,000 women a year here in the U.S., and it ranks at the sixth most common cancer in women. And the number of cases are comparable to those of brain tumors or multiple myeloma. However, having said that, it is truly understudied as a breast cancer subtype. On the next slide, you can see the classical tumor features of invasive lobular breast cancer. On the left side, you can see a picture of an invasive ductal cancer, which is a frequency of breast cancers, and you can see these cells, a lot of cells attach each other, and there isn't much space between the cells. This is very different in invasive lobular breast cancer, ILC. You can see that the cells grow more as a line, and you have a lot of areas filled by other cells in between the tumor cells. So they clearly, from a pathological point of view, they look very different. The majority of ILC are ER positive, PR, which stands for progesterone receptor positive, and HER2 negative. The classical sign, and we come back to this later on, is loss of leukotriene. They are mostly weakly proliferative, as measured by Ki-67. They grow in lone sheets of cells, as I tried to point out here earlier. And there are a number of histological variants. You can see this here on the right side. A few of them are alveolar, solid, pleomorphic, mucinous, and mixed subtypes. I'm now handing this over to Dr. Rachel Jankowitz.
Good afternoon. Thanks for being on the call today. My name is Rachel Jankowitz. I'm a medical oncologist, as they pointed out, at the University of Pittsburgh. But I'm going to go through some of the clinical features that invasive lobular breast cancer has historically been described to have. And I have the word misconceptions in the title of the slide, too, because I think it's not always the case that lobular breast cancer acts the way that it's rumored to act in all patients. And I think we're learning that our care of invasive lobular breast cancer is evolving over time. But basically, because of the tumor features that Steffi described, where the cancer grows in a single file pattern through the tissue, it can be true that invasive lobular breast cancers can be larger in size and can be difficult to detect with mammography. There is a signal in the literature questioning whether there's increased propensity for bilateral breast cancer, and I think a lot of you asked about that in the questions prior to the meeting, so I'm going to touch on what data we have to that regard. Is it harder to excise these tumors, therefore, with negative margins based on their infiltrative pattern? We can talk about that. Are they less responsive to chemotherapy? And also, do they have a differential response to endocrine therapies like tamoxifen and aromatase inhibitors than invasive ductal cancers? And finally, do they have a unique pattern of metastatic spread? So the first slide I'm going to talk about is the radiologic presentation of invasive lobular breast cancer in patients and how that can be challenging. When you look at the literature describing mammographic features of invasive lobular breast cancers, some do actually form spiculated masses like a ductal tumor might, but others show just on mammography a vague asymmetry where if you look at one breast, it looks just very slightly asymmetric in one area compared to the opposite breast. They also can present as an area of architectural distortion, just meaning that the tissue looks slightly abnormal there, but there's not really any discrete mass. And sometimes, even if there is a discrete mass, there can be a lack of central opacity to that mass, making it meaning that it's just less bright or white on the mammogram in that area, less solid looking, and that can make it more difficult to detect. And finally, there is oftentimes less calcifications associated with these tumors that might clue the radiologist into the fact that there's a problem there. So therefore, all of this together can lead to larger tumor size by the time they're found, that are harder to detect and also harder to define the extent of on the mammogram. It's interesting that for a very long time, invasive lobular breast cancer has been, in many studies, been described to have a higher propensity to have bilateral disease in patients. In other words, so a woman finds out she has a lobular breast tumor in one breast and then all of a sudden finds out she also has cancer in the other breast, either at the same time or later. But recent studies have actually challenged that notion. So I think that one's still not entirely clear to us, truthfully. So then, thinking about all this, what other imaging techniques, therefore, may improve outcome for women with invasive lobular breast cancer? There's actually been a meta-analysis, which is a large study collecting the results of many different other studies of the effect of preoperative MRI for breast cancer in general. In other words, when a patient's diagnosed with breast cancer, they get an MRI to define the extent of disease and plan their surgery. So what we know about MRI for breast cancer is that it definitely increases the mastectomy rate when you order an MRI. And when it comes to lobular breast cancer in particular, there was some weak evidence that it may reduce the need for a re-excision rate for patients with invasive lobular breast cancer, but it was at the expense of increased mastectomy. And it actually didn't seem overall that preoperative MRI in this large meta-analysis reduced the risk of either local or distant recurrence. And its effect did not seem to differ based on the histology. And histology means, is it ductal, lobular, another type of breast cancer? So what this meta-analysis was suggesting to us is that although it may be true that lobular tumors are larger, that they may have a higher re-excision rate, the use of MRI to define that, ironically, didn't seem to improve the outcome of the patient. So was it just that the medical therapy took care of it? If it wasn't fully defined, we're not really clear. But that is a conversation we need to have with our patients. I think it's very common practice to order an MRI to define the extent of disease in the setting of lobular breast cancer, but it's also important to know that in certain cases that may not be necessary, and the surgeon might decide that they can see it just fine on the mammogram alone. And a lot of that has to do with the breast density of the patient. In addition, it has been described in the literature that lobular breast cancer is less FDG avid, and that means it's less bright on a PET scan than ductal cancer. And therefore, it is important to look very closely at the CT portion of a PET scan if you're looking for lobular cancer, for instance, in the metastatic setting. And then finally, another recent trial has shown that there may be a role for tomosynthesis or 3D mammography in imaging lobular breast tumors. Tomosynthesis is a technique that allows us to see a 3D view of the breast with a mammogram, essentially, and it can be extremely helpful to pick up architectural distortion, which is, as I stated above, a hallmark of lobular cancer. So that may be a promising technique for better detecting lobular cancers. And so the next slide, I'm going to talk about surgical management and outcome in patients with invasive lobular breast cancer. So at the time of initial surgery and the initial management of the patient, there are higher rates described in the literature of positive margins with invasive lobular breast cancer versus invasive ductal cancer. So in other words, when the patient has a lumpectomy, yes, there is a higher chance that there may be a positive margin and the surgeon may have to go in and do a second surgery with lobular cancer. There's also a higher rate of conversion from lumpectomy to mastectomy in lobular cancer. In other words, you tried to do a lumpectomy, but ultimately got the pathology back and decided to upgrade to a mastectomy because of positive margins. And then finally, there's actually higher rates, like I said, of re-excisions for the positive surgical margins and the use of upfront mastectomy. However, when you look at long-term outcome after surgery, once one achieves a negative margin, there is actually no differences seen in more recent studies in outcome after patients with lobular cancer undergo breast-conserving surgery. So many of you asked, is a lobular cancer diagnosis an automatic indication that I should pursue bilateral mastectomies? And I would have to say no, based on the current trend in the literature. This is obviously a very personal decision that a woman makes with her surgeon, but the data is telling us that it is an option to pursue breast conservation. There's no difference in the rates of local recurrence after a mastectomy either compared to patients with ductal cancer. So actually there was a consensus statement put out from the Society of Surgical Oncology and the American Society for Radiation Oncology that the surgical management of invasive lobular breast cancer should follow the same principles of that for invasive ductal cancer. In other words, you should achieve negative surgical margins, and that is that. So once you demonstrate that and the margins are negative, that is adequate management, even irregardless of what histology is present. And finally, a big topic that has been asked by multiple patients is about chemotherapy response in invasive lobular breast cancer. So we have seen in the literature that there are lower response rates and lower chance of a pathologic complete response with preoperative chemotherapy for invasive lobular breast cancer than for invasive ductal breast cancer. However, this does not correlate to outcome. So I think we have to be careful. So we have to remember that breast cancers that are strongly estrogen positive very rarely achieve what we call a pathologic complete response with chemotherapy. In other words, when patients get chemotherapy in the setting of strongly hormone receptor positive disease, it's very unlikely at the time of surgery that all of the cancer is going to be gone. And we don't expect that. And we have to keep in mind that invasive lobular breast cancer is very often strongly hormone receptor positive. So the lower response rates and lower chance of pathologic complete response in the preoperative setting does not mean that we should make the jump and say chemotherapy is not effective for lobular breast cancer. It may not be the best downstaging tool when you're trying to shrink a tumor prior to surgery. And so more recent studies have shown that if your goal is to give therapy in the preoperative setting to try to shrink the tumor, make a lumpectomy, smaller lumpectomy essentially, that maybe neoadjuvant endocrine therapy may be a more promising approach. So there are fairly high response rates described in the literature to neoadjuvant letrozole, for instance. And there was one study that showed in 61 patients with invasive lobular breast cancer who were deemed not eligible for breast conservation, the use of preoperative letrozole, which is an aromatase inhibitor, allowed actually almost 40% of them to undergo successful surgery at 3 months, and 28% of them more of them to undergo surgery within 12 months. So this is really it in terms of chemotherapy response specifically in invasive lobular breast cancer. There is not a lot described in the literature about that. So I think we need to be careful about extrapolating these preoperative experiences to the metastatic setting. And we talked about that at the conference, that anecdotally as clinicians we have not seen, once we have treated patients in the metastatic setting and we feel that their cancers are behaving in a refractory way to hormonal therapies, we do not think that we're seeing very different rates of responsiveness to chemotherapy in metastatic patients, for instance. once we decide to use chemotherapy. But again, there's not any publications on that topic, and so that's a very important question that needs further research. And so part of another big question that we have for our lobular breast cancer patients, based on some of the analysis that's been done in older breast cancer trials and some of the preclinical work that's being done in laboratories like Steffi's lab, we want to know whether patients with lobular breast cancer, whether their tumors may respond differently to commonly used endocrine therapies than patients with ductal cancer. So we have a clinical trial here open at Pittsburgh, and actually that we're opening up at a number of other sites across the country through the Translational Breast Cancer Research Consortium. And this work is supported by a Komen grant. And it's a very simple trial in design. It's patients with newly diagnosed lobular breast cancer who are postmenopausal. They basically undergo a biopsy of their breast tumor and take 21 days of commonly used hormonal treatments in breast cancer while they wait for their scheduled surgery. And we are going to be sequencing and studying their breast tumors before and after these 21 days of therapy so that we can study. This is the first ever attempt to study in a prospective manner lobular breast cancer tissue specifically in response to endocrine therapy. So we're very excited about that, and we hope to learn from this effort how we can treat in a more meaningful way our patients with lobular breast cancer. And finally, another frequently asked question is about long-term outcome for lobular breast cancer. There is a very commonly quoted rumor or suggestion that patients with lobular breast cancer may be at increased risk of late recurrence. And there is indeed one publication in 2008 that showed that in the beginning, lobular patients in the first several years after they're diagnosed, patients with lobular breast cancer might be less likely to recur, but then there may be an inflection point that occurs at around 5 or 6 years where after long-term follow-up, they may actually be higher risk for recurrence than patients with ductal cancer. And so there's a couple different trials in the literature that have attempted to look at this. The trial on the right here actually showed that when you looked at patients with lobular breast cancer that had grade 2 disease, they actually did inferior to patients with matched grade who had ductal cancer. In fact, they almost did as poorly as patients with ductal cancer who had grade 3 disease. But again, these are just 1 or 2 studies. It does need more attention, and but it may be informative to us, particularly the question about late recurrence in terms of thinking about how we treat patients. We need to pay attention to this in the future.
So this brings us to the topic of metastasis in ILBC. So what you can see here on this slide is actually a very old studies, older than 30 years, where a group looked at metastatic pattern comparing ILC and IDC. And interestingly enough, one of the most striking finding the authors showed was widespread involvement of peritoneal surfaces and retroperitoneum. This was highly significant, the difference between ILC and IDC. So again, the number of studies and the number of patients are very, very limited. But in general, what was described in the literature is that there's decreased metastasis to the lung, increased metastasis to the bone, and there are many more unique sites of metastasis, especially in the GI tract, the peritoneum, and the ovary. We actually here at our site, we set out to look at this in our database. So this is a single institution experience, and we have a prospective registry of metastatic breast cancer where we have fully abstracted medical records and outcome data. This is data between 1998 and 2012. A lot of it is run by Dr. Peg Rosenzweig here at the University of Pittsburgh. So she collected information for 761 patients, either with ILBC or IDC, and you can see the expected split between ILBC and IDC. The first thing we found was that patients with invasive lobular breast cancer recurred with distant metastatic disease later than those with ductal cancer, and there were significant differences in the site of metastasis. And this is both with respect to the first site of metastasis as well as throughout the course of the disease. And that's shown here in a model on the right side of the slide. So we saw fewer metastases to liver and lung, but we saw more metastasis to the GI tract as well as the bone. If you specifically look at the timing of recurrence, we actually saw also an increase in metastasis to the ovary. So this is, of course, of great interest to us, and we have now developed a program here at our university where we try to collect as many metastatic lesions to the ovary and to the gastrointestinal tract. So far, we have collected 28 metastases to the ovary and 12 to the GI tract. We have started to sequence those. Actually, before I tell you about the sequencing, I just want to show you we can stain these metastases, and we can see that the pattern of loss of ecdyterin, which is shown by the pink staining, is maintained in these metastatic lesions as compared to metastases from ductal cancer, which have this brown staining reflecting presence of ecdyterin. We are sequencing this, and these studies are ongoing, and we really need to have a much larger number to get meaningful data. But we can, I can tell you already that the metastases clearly look very different from the primary tumors. So this is an ongoing goal, and this is a big research interest we have. I want to tell you a little bit more about the molecular biology and the genetic makeup of invasive lobular breast cancer. There was a paper published last year which for the first time really comprehensively characterized a large number of primary invasive lobular tumors. Here's the reference for this paper. I'm going to summarize the main findings for you. The absolute main finding and the hallmark of ILBC is that ecdyterin, a protein which mediates cell-cell attachment, is lost in more than 95% of the tumors. And this can be by mutation or loss of the gene or just protein downregulation. And you can look at this in clinical samples. You can either do just histology, or some groups do staining for ecdyterin, where you see brown staining in ductal tumors. You do not see this in lobulars. Or you can do this dual staining, which I explained briefly before. And ductal, you get a brown staining, and then lobular tumors, you get a pink staining. And here on the top of the slide, you see the other main findings from this large study. I think, as we mentioned before, Dr. Jankowitz mentioned this, there are more estrogen receptor positive, more luminal A tumors in lobulars as compared to ductal tumors. And then something else, there are 3 genes and pathways I quickly want to mention. There are 2 genes, one is called FOXA1 and one is called GADA3. Both of them regulate activity of the estrogen receptor, and there are significantly different number of mutations between lobular and ductal cancers. And the other pathway, which was differently affected between ILC and IDC, was a pathway called P10. So this is really, at the moment, if you think of the primary tumors, these are the main differences in the genetic and molecular makeup. A question which came up a few times is this of mixed IDC and ILBC. And in this paper, it was really the first time that we looked at this molecular makeup of these mixed tumors. And at our conference, the senior author, Dr. Chuck Peru, actually talked about this. And to briefly summarize, basically this comprehensive molecular analysis, what we were able to show is that these mixed tumors can be separated either into ILC or into IDC. And hopefully at one point we'll have personalized medicine for ILBC or for IDC. And I think at this point the ability to say a mixed tumor looks more like IDC or looks more like lobular cancer will be very important. What else do we know about genetic makeups of lobular tumors. There are a couple of studies now published, and this is shown here on the top of the slides. These are the numbers of these tumors. Again, these are mostly primary tumors, and they looked, the groups looked at DNA or they looked at RNA. There are two important findings I want to share with you. One is that there were quite a few tumors which had mutation in HER2 and HER3 genes. This is important because we now have very good targeted therapies for tumors which are driven by active HER2 and HER3 signaling. The other interesting aspect we learned from these studies is that there are molecular subgroups within ILC tumors. So not every lobular tumor is the same. And so there are two separate studies which looked at subgroups, at molecular subgroups within lobular tumors. And you can see there is at least partial overlap what those two groups found. The TCGA study divided the tumors into three subgroups. One was called reactive, one immune-related, and one proliferative. The group by Michaud et al. From the WABA consortium showed two different subgroups, one hormone-related. Most likely this is very similar to the proliferative subtype, and then again one immune-related. The identification of this immune-related subtype is of interest, obviously. There's a lot of exciting findings in immune therapy, but at this point in time, we really do not understand this, and more work is needed. ILBC is clearly a very hormone-sensitive disease. This was presented by Chris Leigh at the ILC Symposium, and what he showed that if you compare menopausal hormone use and you compare the risk for developing ILC or IDC in general, the risk for hormone use is much higher for developing lobular cancer compared to ductal. And this is the case if you use estrogen, or it's even more pronounced for the use of estrogen and progesterone. I don't want to go through this in detail. If people are interested, I'm very happy to answer questions subsequently on the phone or per email. But we do have models in the lab where we can grow cells representing ductal cancer or lobular cancers. They express, for example, estrogen receptor, very high actually, and equiterrin is lost. We can stain those, and we can do multiple experiments. We looked at experiments. We looked at hormone response in these models, and we can see that they are very nicely estrogen responsive. We can inhibit them with anti-estrogen, and actually Rachel is going to talk more about this. And we can see regulation of classical estrogen target genes, but we can also see other pathways which were activated. And I want to highlight the FGF receptor pathways and pathways which we call EMT, or epithelial mesenchymal transition. I give this over to Dr. Jankowitz again.
So part of the signal that we've seen in the laboratory in terms of how cell lines that are lobular breast cancer cell lines may respond to endocrine therapy differently than ductal cancer cell lines has laid the framework for our clinical trial that we have open. This slide shows MDA MB134 cells, which are lobular breast cancer cell lines. And what the slide is showing that in the presence of estrogen, which is this black line, the E2 line, that when you treat these cells with various hormonal therapies and estrogen at the same time, the ICI is in the laboratory the equivalent of fulvestrant, which is a commonly used hormonal therapy in breast cancer, and the red line is the tamoxifen. You can see that these therapies do inhibit growth, whereas the red line drops the cell growth off with tamoxifen and with fulvestrant. But the growth is inhibited a bit more, you can see, with the fulvestrant than it is with tamoxifen. What's also interesting about this condition is that when you remove estrogen and you grow the cells on the plate in the absence of estrogen, tamoxifen actually seemed to induce growth in these cells, and that's represented by this red line at the bottom here, and they were still inhibited by the use of fulvestrant. So this does appear that there's a partial resistance to tamoxifen in this cell line, and we do need to be careful that this is just a cell line. It is not a patient, but that is somewhat in keeping with an analysis that was done in patients samples from the Big 198 trial on the right. What you can see here are disease-free curves for women who were postmenopausal who received either tamoxifen or an aromatase inhibitor called letrozole. And what you can see is the dotted lines represent patients with lobular breast cancer, and the solid lines represent patients with ductal cancer. And this was presented by Dr. Metzger-Philo, Otto Metzger, who was also part of our invasive lobular breast cancer symposium here. And what he presented were that the benefit of receiving an aromatase inhibitor over tamoxifen was proportionally higher for the patients with lobular breast cancer than it was for the patients with ductal cancer. And you can see that how far apart the curves are for the dotted line, meaning the dotted blue line represents patients with lobular, sorry about that, I'm having a hard time. The dotted blue line represents patients with lobular breast cancer who were treated with letrozole, and the dotted yellow line represents patients with lobular breast cancer who were treated with tamoxifen. And you can see there's a big difference in disease-free rates favoring the letrozole in the lobular breast cancer patients, the patients with lobular breast cancer versus the patients with ductal cancer. The two lines were much more closely opposed. And so there are some ongoing clinical trials, including patients with invasive lobular breast cancer. One, which I already mentioned, is our own. This is the only one that is purely for patients with lobular breast cancer. It is the preoperative window trial we have here looking at endocrine response. The second one is by Dr. Metzger and colleagues. It's a randomized phase 2 study of palbociclib with endocrine therapy versus endocrine therapy alone. This does include patients with both lobular carcinoma and ductal carcinoma, but they are planning to look at the subset of the lobular patients specifically. And finally, the third trial is being done with the Netherlands Cancer Institute, looking at the safety and effectiveness of GDC0032, which is tecelisib, a PI3 kinase inhibitor, when given alongside of tamoxifen, and this is in an advanced breast cancer setting.
So the next two slides I will basically summarize, and again, I think I'm very, very happy to talk to people afterwards or email. This slide is just to present models we use in tissue culture to study invasive lobular breast cancer. On this slide and on the next slide, I summarized mouse models we use to study invasive lobular breast cancer. In the interest of time, I think I will not go through them, but I will now summarize on this slide what we discussed at the symposium, and then I will hand this over to Leigh. So to summarize, invasive lobular breast cancer has unique clinical and pathological features. It is a steady loss of leukotriene as a hallmark of lobular cancer, but there are other mutations, such as mutations in FOXY1, HER2, HER3, and the loss of PTEN. We have increasingly more models available to us, but it's still insufficient. ILBC is a hormone-responsive disease, both to estrogen as well as progesterone, and there are clearly some distinct ER activities which we need to understand better. There's evidence for some tamoxifen resistance, but it's not conclusive, and additional studies are needed. With respect to metastasis, there's less involvement of visceral organs, especially lung and liver, and there's more metastasis to bone and unique sites, like the GI tract, peritoneum, and ovary. And I will now give this over to Leigh.
Hi, this is Leigh out in Seattle, and I'm a patient advocate, and I was diagnosed with lobular breast cancer 5 years ago, stage 2B. And like many of you, mammograms, I suspect many of you, mammograms missed mine. The only reason I think mine was found at stage 2B is because I had a ductal carcinoma in situ immediately adjacent to my lobular carcinoma that formed a lump that I found myself. Like many of the 30 advocates who came to Pittsburgh, we were really excited to actually have this symposium happen. Very excited to be invited as advocates, and really want to thank Steffi and Rachel and everybody, Dr. Musk, everybody who made this happen, because it doesn't take very long to realize as a patient with lobular breast cancer that there's very little information out there about your disease. And so we were excited to be able to be part of this and to try to move it forward. We, after the conference, we have come together, and we're still forming a group, the working title being the Invasive Lobular Breast Cancer Advocate Group. And we're pulling this together now, and we've come up with some advocacy opportunities to advance our disease, and within the breast cancer community, within researchers, and I just want to give you a little bit of an overview about some of the things that we're thinking about. The ultimate goal is essentially to increase the knowledge about our unique breast cancer subtype, and the opportunity to promote the opportunity to improve all aspects of our disease, and that's from diagnosis through treatment and through follow-up care. And so what you see on your screen here are some specific advocacy opportunities that we've identified, and of course understanding that these are all very complex. Each of these small bullet points are really complex ideas with multiple subtopics. So these bullet points don't hit everything. But number one is the problem with reliability in screening and imaging, on diagnosis, and on tracking and finding metastasis, and just identifying reliable tools. Then also is encouraging collaboration among researchers from different institutions with different expertise to better understand the unique metastatic behavior of invasive lobular breast cancer, and to characterize metastasis and better understand the subtle signs of recurrence. Many patients go misdiagnosed or undiagnosed for long periods of time with metastasis because they're not looking for metastatic disease in the ovaries or the GI tract or other places. Accelerate research into the molecular alterations and the genomic differences that might enable future targeted therapies, and Steffi referred to some of that. Improve patient education to provide better and more comprehensive support for patients with invasive lobular breast cancer, and as many of us patients know, it's often up to us to tell our doctors that we don't just have breast cancer, we have lobular breast cancer, and what that can mean. And so try to think of ways to promote that the information of what lobular breast cancer is and means to us as patients. To reanalyze existing clinical trial data sets that combine all estrogen positive cancers and evaluate the differences between ductal and lobular breast cancers. So right now there's a lot of research that's under the guise of ER estrogen positive or progesterone positive, and they put lobular and ductal patients together. And part of what we hope to learn something from is to actually pull lobular breast cancer patients out. And this also gets more into promoting more lobular breast cancer patient inclusion in clinical trials in general. To conduct clinical trials to better understand the differences in standard of care treatment between lobular and ductal cancers, and include inclusion of lobular patients in trials, in all trials, and that's early stage treatment, metastatic. Again, we're not going to learn anything if we don't include patients in the trials that are studying it. Integrated designation for lobular within medical records and educate medical professionals on the unique presentations of the disease, especially at conferences in medical and in professional settings. So one of the things with this is medical records, and this was kind of startling to learn at the symposium, is medical records call us all breast cancer patients. But if you're actually doing, say, a scan for bone pain or for abdominal pain or something, it may well be different. Knowing that you're looking for lobular breast cancer instead of ductal breast cancer can make a difference in it makes a difference in what, say, a pathologist or a radiologist looks for when they're doing the scan. So as a patient, it's important to always remind all your doctors you are lobular. You're not just you're not just general breast cancer, so that they put that in your records. But also, when we're looking at ways to perhaps insert this as part of record keeping in general. And they also have, one good provider and researcher opportunity to help raise awareness is at the conferences and meetings where professionals get together and they share information, and also just raising awareness and some of the most current research at these professional conferences we think is important to just promote awareness of the differences. And then finally, designate grant funding specifically for lobular research and clinical trials. I don't know how many specific lobular trials there are right now, but it's not that many. I don't believe. So what we're doing next steps, we're brand new. We as a group, brand new as in we formed a steering committee last month. We have a white paper that's drafted and in process right now that is kind of an overview of these goals and these opportunities that I just went over with you on this slide. We're going to be planning ahead for some specific actions for how we can promote some of these goals this spring via steering committee. And we're going to, again, hope to meet again, if not before, at least in Boston in 2018 with progress from actions between now and then. In the meantime, I would love to send you to a nice organized group with a sign-up page and all of this information, but we do not have that yet. And so the best place to get more information about advocacy opportunities is there's a Facebook group. It's a closed group. If you're on Facebook, it's Lobular Breast Cancer, ILC Invasive Lobular Breast Cancer. You'll find it. And we are posting all current research. We'll have these share slides. We publish all of these information. And this is also a group for people who have been diagnosed with lobular breast cancer to ask a lot of questions, and there's a lot of patient support with other patients on that page. So that is one opportunity. The other is there is an invasive lobular breast cancer forum on breastcancer.org that's active. So both of those are the places I would send you for now to look for additional information as we unfold future advocacy efforts and to figure out, and we'll communicate out through those forums about how to get involved.
Thank you, Leigh.
I think we'll end at this point. I mean, the slides, the presentation, I just want to say, thank you to all the researchers and clinicians, to the participants and organizers of the ILC Symposium, the advocates who help now to drive this forward, to the patients who have graciously donated their tumor tissue. And I would like at this point also to say that there might be opportunities in the future to work with us, and maybe there will be some information forthcoming on the MBCN website. So if you are interested, you can look at that there over the next few weeks. In the meantime, if you have questions, which we will not be able to answer today in the remaining time, feel free to contact me at my or at Rachel's email address shown here on the slide. And I think now we are open for questions.
Thank you all for an incredible presentation. I'm going to jump right in. We have about 7 minutes left, and there are a bunch of questions. So the first question, given the frequency of ovarian mets, what role might an oophorectomy play in both early and late stage?
That is an interesting question. We know that there's a higher rate of ovarian metastases. In my experience, they don't tend to cause a lot of symptoms the way that the GI and peritoneal metastases cause. I would say at the current time, the only role for removing ovaries in the setting of breast cancer is if you're doing it with the explicit purpose of adding ovarian suppression to someone's care. And generally, we consider doing that for very, very young patients under the age of 35 who are higher risk, or patients who remain premenopausal after chemotherapy in the early stage setting. We take that information from the analysis of the SOFT and TEXT trials that showed those were the groups who had the greatest benefit from that approach. Unfortunately, there was no analysis specifically to lobular cancer in that trial.
Yeah, I mean, that's a really good question. Maybe in the future we can actually find out genetic drivers, molecular signatures, which predict metastasis to the ovary, and then maybe that question can be re-asked.
Thank you. Excuse me. So in the case of metastasis to the GI tract, which can't be scanned and therefore can't be measured, people are unable to participate in a clinical trial. Is there some way that people with metastasis to the GI tract are able to participate in a clinical trial?
That's a very frustrating issue in the metastatic setting to have what we call non-measurable disease. And there are a lot of clinical trials that require, quote, measurable disease. However, there are a lot that do not as well. In terms of what we can clinically follow in those patients, sometimes tumor markers are helpful, sometimes they're not. I do think that we need to be attuned to that when we develop clinical trials for our patients, because I always find it extremely annoying if I'm trying to get a patient on a trial and it requires measurable disease and therefore they can't do it. As a physician, I find that frustrating. I guess I don't have a great answer to that question. It is a source of frustration and one that I think we need to be very attuned to. I'd love to see trials designed for women with metastatic invasive lobular breast cancer. We're in discussions here about that, and I certainly would not put that as an exclusion criteria if we did that, obviously.
So several people are asking about how they can help move research forward. Could they donate medical records or tumor samples? Or what about the Metastatic Breast Cancer Project?
Yeah, so we are actually in discussion with the leadership of the Metastatic Breast Cancer Research Network. And again, I think discussion is still ongoing. I think they are very interested in this, and I think it will be good to go back on the website there maybe in 1 or 2 weeks, and surely not to others, I think we'll post some information about this.
Okay, great. And there are several questions about what methods are used to detect the spread of ILC.
So generally, we do not look for spread before it happens in any routine way. And I know that that's an incredibly frustrating answer to patients, but they have done studies where they've looked at sort of routine use of scans or blood work in early stage breast cancer patients and whether that translated into better patient outcomes, and the answer did not appear to be the case. There are many people who do not develop spread of their breast cancer. So generally, we do physical exam and symptom assessment, and I know that's such a frustrating answer. We have not found a better way to survey for micrometastatic disease that is actionable yet. So it is possible to measure things like circulating tumor DNA and circulating tumor cells in the setting of clinical trials. This has been done, and we know that patients who have circulating tumor cells, for instance, in their blood are higher risk of developing metastatic disease. But right now that test is not routinely available in the clinic, and what we don't know is whether that is someone who's destined to recur because of that, or whether they might continue to keep those circulating cells in check via medical therapy, a combination of their own immune system, et cetera. So that is still very much an area of much needed research, how to survey early for the development of recurrence.
Okay, what would be considerations for treatment options with pleomorphic versus non-pleomorphic ILC?
I think pleomorphic generally confers a higher grade phenotype to the tumor, and what that means is when the pathologist looks at it under the microscope, a high-grade tumor is one that divides and grows quickly. And therefore, a lot of us, that means we're going to consider chemotherapy for pleomorphic invasive lobular cancer. And I don't know that we know a whole lot else besides that, other than it has been described that pleomorphic invasive lobular breast cancer has a higher propensity to have HER2 mutations. We are seeing that in the described molecular analyses of ILC tumors, and that might be one area where we can really exploit that therapeutically, because if their HER2 mutations are not typically picked up via normal HER2 testing in breast cancer, we pick up amplifications via immunohistochemistry and FISH testing, but we don't normally look for mutations. And I think that this is a really important signal that we're seeing for cancers with mutations, that they may very well respond to HER2-directed therapies. So that's important to know, and we need to pay attention to that.
Okay, and one last question. So as community health advocates, what specific information would you like us to take to the community from this presentation today?
Well, one thing that I'd just like to plug personally is our clinical trial. Like I said, it is a concerted effort to study and sequence lobular breast cancer before and after endocrine therapy. It is now going to be open not only at our site, but at MD Anderson is now open. Mayo is open. Indiana is close on the heels of opening. We're opening very shortly at Washington University. So there's a number of different sites across the country for this trial. The kicker is it's for newly diagnosed patients, and it's while they're waiting for surgery. So there's a very short window of opportunity for patients to be enrolled on this trial. So we're trying to raise awareness for it, and we'd like to send that message out.
And maybe, Leigh, can you hear us?
Yes.
Maybe you can say a few words in response to this question.
I think that I think as advocates, the most important thing is to continue right now is to continue to learn about our own disease and to keep raising it locally with your doctors, with your if you're affiliated with a research university, or even with your organizations if you're working with one of the breast cancer organizations, and keep putting lobular breast cancer on the radar screen as a unique disease and something that requires a lot more research to understand and treat appropriately and screen for appropriately. And part of what we're going to try to do is to put some better tools out there and at least make them available through this Facebook group and the breastcancer.org group, if not more broadly, that will help you do that.
Well, thank you again to our presenters, and a special thank you to the Metastatic Breast Cancer Network. They're the ones that came up with the topic and got Cher in touch with the wonderful presenters that you heard today. Thank you all so much. If you wouldn't mind taking a minute to fill out the evaluation at the end of the webinar, we'd appreciate it. Thanks so much, everyone.
Thank you.